Good evening, everybody. I think the session today was billed as a faculty lecture, and I converted it into a group discussion. Uh, Basically, because I think the retention and understanding is better when there's a discussion. Uh, After a regular didactic lecture, only about 20% of it is retained by the end of 4 to 8 weeks. Okay, and so, but if you have a discussion, the retention rate is more like 40%. And if you give the lecture yourself, the retention is about 80 to 90%. So it's always better to have a discussion rather than a faculty lecture. And that's why I converted this. I hope all of you read a message to that effect in this morning's group WhatsApp, and hope you have all put in your effort to come in. And I'm very pleased to see that, Dr. Guru Shantapa is here. Good evening, sir. Ravi.
Sir, good evening, sir.
Good evening, sir. Dayanand Noli. Very senior people are here, and I'm sure the students will benefit from all the discussion that we're going to have on various aspects of laparoscopy. We're going to keep it very basic because this is billed as the basics or principles of laparoscopy. Okay. Now,
and Rajshekhar is there also, sir.
Rajshekhar,
Yes,
I greeted him even earlier. He was one of the first to come. Yeah. It's laparoscopy is also called minimally invasive or keyhole surgery, as we all know. It came as a breath of fresh air in the early 90s. When general surgeons had an identity crisis, we didn't know what we were. So many specialties and subspecialties were taking away everything from us that, we perhaps were left with some hernia and hemorrhoids and nothing more after that. And so when the situation was like that, laparoscopy came and all of us jumped on to the bandwagon. And what it did was to expose a wide area of activity to the general surgeons. We could go and, doesn't happen nowadays, but we could go and help gynecologists, urologists, and you name them, thoracic surgeons, all of them in a laparoscopic or thoracoscopic work. And so a kind of relief it was when the science of laparoscopy came into being in the late 80s and early 90s. But when you have such a vast expansion, it has its disadvantages. We had many, many mishaps. And so in the late 90s, it came about that we really started understanding and teaching laparoscopy in a formal way. And what you're going to now discuss in this particular meeting further on is all those principles that we have learned. And I'll start off with one of the advantages, one of the main advantages of laparoscopy, which is a reduced metabolic stress. We all know that the body responds with a stress to any kind of injury. Surgery is controlled injury. And if you reduce that degree of injury through a laparoscope, it is very likely and it is very clear that the metabolic stress is less. Now, can I ask Indraja, what are the other advantages of laparoscopy?
Hello, sir.
Yeah, go on.
Yes, sir. Sir, the recovery will be like early recovery, sir.
Yes.
And length of hospital stay is less.
Yes.
And better scar, sir, compared
Yes.
to the open surgery.
Yes.
And the metabolic response also is.
We have mentioned it.
Laparoscopy.
We have mentioned it already.
Yes, sir.
This is very important. Much
Yes.
less pain than anything else. And because there is less pain, there is reduced metabolic stress. And as you rightly said, early recovery and better cosmesis. There is no scar. I mean, not to say it's a better scar, practically no scar. And so you have a better cosmesis. Now, what is laparoscopy? Nikita?
Sir,
What is it? What is the word derived from, and what does it mean?
laparos means abdomen, sir, and scopy means
visualization through the whole
Yeah.
to see.
Yeah. Okay. This is what it is. All right. It's a Greek word and it means the abdomen or the inside. And technically it means the flank, but it is generally in general discussion actually means the abdomen. And it to see inside, scopy is to see inside, and that's what it is. Okay. Now, history and landmarks are something that I'll just run through. These are important, but not directly in terms of learning of laparoscopy. George Kelling, as early as 1901, did a laparoscopy in dogs. And the first human laparoscopy is attributed to Jacobius. J is pronounced Ya, okay, Jacobius. And he used a cystoscope. And remember, those days, they didn't really have any lens systems. Just a nice thin tube. He made a hole in the umbilicus and put it through that. They were using it as cystoscopes, putting it through the urethra into the bladders. And so he used that, and very little light, have perhaps some open light, lighting it from the outside, and God knows what he could see. But definitely he did put a scope into the tummy. That is recorded. Verres from Hungary in 32 discovered the Verres needle. It was done actually to protect the lung, and it was used for thoracentesis. And so the same thing was adapted by the general surgeons for use in the abdomen. 1954, Hopkins discovered the solid rod length system that we use even today in our laparoscopes. And this gentleman working in the United States, actually he was an Indian origin, but working in the United States, is a pioneer in the field of fiber optics. And you know that we use laparoscopy, even though it's much more commonly used in endoscopes, we use light source as a light source, the cold light source. We use we use the fiber optics, the principles of fiber optics. Okay, and Kapani is the person who's attributed the pioneering work in fiber optics. Kurt Sem from Kiel in Germany, a gynecologist by profession, did the real, what can I say, donkey's work, the real basic work in operative laparoscopy. Okay, he is the one who actually designed and got Karl Storrs to make all those instruments in the 60s. Philip Moray in Lyon is attributed the first published laparoscopic cholecystectomy, even though there is another name, I forget the name now. He's supposed to have done it the previous year, but was not given the attribution that he deserved. Ravi, do you remember the name of the other person?
No, sir, I also forget.
Yeah. So there was another person, but by and large, the world recognizes Philip Moray as the person who did the first lap chole in humans. What is interesting is that 1989 was the first laparoscopic cholecystectomy, and by 1990, the first laparoscopic cholecystectomy was done all over the world, including in India. Tempton Udwadia did the first laparoscopic cholecystectomy in India the very next year. And we did the first laparoscopic cholecystectomy in Bangalore in 1992. I went in 91 to UK to learn laparoscopy. And so you can imagine, normally, you would have about 10 or 15-year lapse before something is introduced in the West and it is taken up in India, at least. But as far as laparoscopy is concerned, laparoscopic cholecystectomy is concerned, the lag period was less than 3 years. And so it really spread like wildfire across the world. But as I said, it brought with it some of the dangers like damage to internal organs, particularly the bile duct during cholecystectomy. And that was because of lack of training and lack of real understanding. But that is history now, because from the late 90s onwards, many associations and many surgeons started formal teaching and formal learning of laparoscopy. And so it's now a very safe and well-established science. One of the first requirements is that the abdomen is only a potential space. You need space to work in. And so the first challenge that laparoscopists face is, how do you create space? Okay, can I ask Pavan, how do you create space?
So, by injecting, by creating pneumoperitoneum, sir, either by injecting carbon dioxide or
Okay.
nitrous oxide, sir. Not.
Okay. Yeah.
Yes, sir.
Is there any other way of doing it?
So that means closed and open space we will do, sir. That means closed technique and open technique.
What is the open technique? Is this insufflation of gas closed or open?
Insufflation of gases through various needles are closed technique.
Oh, okay. You're talking about, okay. The various needle technique and the open method
Yes.
of putting gas. I'm asking, other than putting gas, is there any way of creating space?
Sir, injecting saline or water. So,
Will it really create space enough to do a surgery inside?
but it acts as a conductive medium, so
Yeah.
it won't.
All right. I see a few more names. Please identify yourselves because you're probably pretty new to the group. Anirudh,
Lakshman sir, there are a few of our postgraduates have joined. Sir.
very nice, sir. Really nice.
I have put in my HOD group.
Very nice.
So maybe
Very nice.
our postgraduates have joined this program.
Very nice. So, we'll involve you also in a discussion, postgraduates from elsewhere. This is nothing exclusively for
No
Sagar.
problem, sir.
So please open your, unmute and then contribute. Anirudh, can you unmute and say, is there any other way other than insufflating some gas to create space? Anup, are you there? All right. Nikita, go to our own.
Yes, sir. Retracting or lifting the anterior abdominal wall, sir.
Yes, very good. Very good. What is it called? It's a
I'm not sure of
laparoscopy. It's a laparoscopy and it's a lift. So what is it?
lift.
It's a laparolift. Okay, you can either mechanically lift it or you can insufflate with some gas, as Pavan said. Okay, can you think of some advantages and disadvantages of the lift procedure?
Sir,
Lift.
Advantages would be what all the complications which are caused by the carbon dioxide.
Okay,
Those
very
should be
good.
minimized, sir.
All right, you don't use carbon
Also, the
dioxide.
pressure, increased intra-abdominal pressure, which is also causing complications. Those could be
Yes.
minimized.
Very nice,
And-
very good.
And I think the disadvantage of lifting would be the abdominal wall, there would be damage or some kind of injury, sir.
You can damage the abdominal wall, yes. What
Hmm.
would be the quality of space that you get when you lift it?
Relatively less than the insufflation, sir.
Not only less, it is asymmetrical and less comfortable to the surgeon. Can you think of one more advantage? You have talked about the lack of disadvantage of intra-abdominal pressure, disadvantage of carbon dioxide. Is there anything else that's of use? You can use normal instruments. You don't need the trocars. You may need the trocars. You may use the trocars, but you don't need a gas leak proof arrangement. And all you need is some long instruments. Okay,
Yes.
and so you perhaps can put some more sturdy instruments and do things, but still it's never gained popularity because the space that I've actually tried long ago, using a laparolift, and the kind of space that it gave you was asymmetrical. It was with a cupola, and where you really wanted space, you wouldn't get it. So it was never comfortable. It was very cumbersome. You had to really struggle hard. And this is the picture of an Indian adaptation of a laparolift. But as I said, it didn't have much of a popularity.
Sir?
Yeah.
Would it not cause more post-operative pain because of the muscle being lifted for a long time?
That wasn't one of the main issues, unless there was some damage to the abdominal wall. In the process of putting it in, you could actually tear muscle, in which case, or get a hematoma. that would give trouble. But if you really got it in smoothly, I remember, listening to lectures and reading something about it long ago in the 90s. Increased pain was not one of the issues.
Not one of the, okay.
Not one of the issues. Yeah. Okay, we talked about insufflation of gases. And so we then, it's good, yeah, correct. Let me just, I'm looking at the chat box, and Ravi has enlightened us. It is Eric Muhe, who was the person who did the very first lab collie. Yeah, that's right. I remember it now. Okay. So Anirudh, if you're there, which gas can be used? And we mentioned carbon dioxide. What other gases can be used, and what would be the advantages and disadvantages of each of those?
Good evening, sir. This is Anirudh.
Good evening.
Sorry, I could not catch your last question because of some network issues.
No problem. Have you got my present question?
Yeah, sir. Nitrous oxide can be used,
Yes.
but it can.
We have lost you. Some bandwidth issue.
Diffuse into the blood vessels and cause toxicity.
Okay. Why would you say it causes toxicity? Nitrous oxide is directly inhaled during anesthesia. So it's not, toxicity is not the main issue.
Nitrous oxide can be used toxicity.
As I said, nitrous oxide should not give you any toxicity because, it's actually directly inhaled as a part of your anesthetic system. It does something else. I think we have some network issues. Okay.
So it has kept, that's it. Okay.
Yeah.
So you just need to clean it daily.
Okay.
Can do it at home only dressing.
Yes.
So now I will get it cleaned. There is one.
There is.
gel which
Niranjan, I think, was talking to somebody else. Yeah. Okay. Anup, we have some problems with Anirudh. Anup, can you take this question? What are the other gases? He mentioned about nitrous oxide. What are its other disadvantages? I don't think its toxicity is a main issue. What else can it do that might hinder laparoscopy? Pavan, have you read about it?
Sir, it slowly absorbed, sir.
Okay.
And sir, it accumulates in the empty spaces, sir.
Okay.
So causing.
Like what? It diffuses very well.
Yes, sir.
And so where does it get accumulated? All right, I'll come to that when I have the answer. What other gases can be used? Can air be used?
Yes, sir. Air can be used, sir, and oxygen also, but these are combustible, sir.
Okay. So how can it be used then if you say it's combustible?
That's what,
What is the other
so
disadvantage
ideally,
of air? People used to do tubectomies with air, they would just pump air in, and I don't know if it's even done even now, but earlier it used to be very routine. But what is it that you cannot do in laparoscopy when you infused air?
Sir, cauterizing, sir.
Cannot use cautery. What else? It is not soluble, right? At least the nitrogen in the air is not soluble. So what happens if one of the blood vessels get opened up when you're operating inside?
Embolism, sir, air embolism.
Air embolism. It doesn't settle, it doesn't dissolve, and so you can have air embolism. So I think air should never be used, even if you do not use cautery. But where it is used in, air is used in tubectomy in camps and government hospitals. Yes, I know. That's what I mentioned. But yeah, I suppose in a desperate measure you could do it, but I do not think carbon dioxide is very expensive. And so perhaps you should stick to that. What else? Is there any other gas that can be used? All right. Argon is an inert gas, again soluble, and it can also be used, but it's extremely expensive. That's the problem. That's why we don't use it. Air can cause air embolism, can cause explosion during cautery. Carbon dioxide is the solution of choice, is the gas of choice because it dissolves well and easily available, no explosion risk, and relatively cheap. Nitrous oxide diffuses into the bubble. So if you use it for a good length of time, particularly in long laparoscopy procedures, there can be a huge distension of the bowel, and that can actually reduce the available space. Yeah, Guru Shantappa sir has mentioned just that. So it can actually cause a lot of distension. And even though you have a good distension from nitrous oxide, that will be compromised by the distended loops of bubble. Okay, so that is why we use carbon dioxide for all these reasons. Easy availability, dissolves in blood, no explosion risk, cost is reasonable, and doesn't cause any dilatation of the bubble. All right. Yeah, that is about the gas. Now, insufflation problems are many. You know, Nikita mentioned about the effect of the pressure and the effect of carbon dioxide itself. Also, the main effects would be on the respiratory system and the cardiovascular system. So who can take this question now? Mahna Sultana, can you unmute and tell me what the problems would be as far as the mechanical issues are concerned and as far as the metabolic issues are concerned. We'll restrict ourselves to carbon dioxide, but because that's the one that we use universally.
Mechanically, if the insufflation, if the pressure is too much, then that can cause respiratory depression.
Respiratory depression. Can it do anything to the heart, to the cardiovascular system?
So
Why would it cause respiratory depression or difficulty?
Excessive distension of the abdomen
Yes. What does it do?
would push the
Splints the diaphragm, lifts it up, and then so your vital capacity comes down. Yes, I agree. And that can cause respiratory difficulty. Okay. What about the heart? What does it do?
and compress the IVC, so
Yes.
reload.
Yeah, very good. So you can get hypotension. Very good. Does the splinting of the diaphragm have any effect on the heart?
Yes, sir. Like it would also cause like a restriction.
Yeah, it lifts the heart up as well and changes the axis of the heart. So the output, cardiac output, can be adversely affected not only by reduction in the preload, but also in the change in the axis of the heart, resulting in its pumping activity. Okay. Anything else? So you'll have to give me more details about what the the mechanical effects on the lungs are. We mentioned one about vital capacity being less. Anything else?
Would,
All right, we'll come to that later. Let's now look at the pneumoperitoneum and its serious effects, cardiovascular effects. I mentioned because of increased intra-abdominal pressure, IP, and because of carbon dioxide. So can you sort of fill in the left half of all this?
so the carbon dioxide tends to diffuse into RBCs almost 20 times more than the regular air, like the oxygen. So it would cause hypoxia as well.
Yeah, not because of RBCs. You know, it's just that carbon dioxide dissolved in blood. It's not just the RBC. It's in fact even dissolved in plasma. And so your lung may not excrete it the way at the speed in which you want it. But let's come back to the cardiovascular effect. So what are the things that you would measure when you're looking at its effect on a cardiovascular system? I'll give you one hint. Heart rate. Okay, I'll give you a second hint. Systemic vascular resistance. I've already mentioned the third one earlier. So like that, what can you mention?
Hypotension.
Yeah, that is blood pressure. Okay,
Yes.
blood pressure. So we now have 4 parameters: heart rate, cardiac output, blood pressure, systemic vascular resistance. Anything else that you can think of?
Reload.
Yeah. Okay, these are the things. So you can see that the intra-abdominal pressure has one kind of effect. The carbon dioxide may have similar or a different effect, completely the opposite of what happens. The degree of each of these effects can vary. That's how I have shown it in the number of upward or downward arrows. And sometimes it may be high, sometimes it may be low. That's how I have shown arrows in different directions. So if you look at the pneumoperitoneum effects because of increased intra-abdominal pressure. Arterial pressure will be high because of both. Vascular resistance will be very high. All right. If the pressure is so high that it reduces the preload significantly, this pressure can actually come down. CVP can be variable, cardiac output will be low, heart rate will be high, and stroke volume can be variable. So what we're describing in this chart is that there are effects of intraperitoneal carbon dioxide, both because of its pressure, mechanical effect, and its metabolic effect, and it can be variable. The sum total of all this is what you actually see when there is a problem. And if there is a mild increase in heart rate, mild increase in blood pressure, or a mild variation in CVP, nobody bothers. But the thing that you have to look out for is a sudden decrease in the patient's blood pressure. Okay. If the patient, what we call crashes when you induce pneumoperitoneum, what do, Manas?
We have to immediately remove the trocars.
Perfect. You don't even have to remove the trocars, but let the gas out first. The first thing you do is let the gas out. Get the patient horizontal if you have got the patient head up for your lap collie, for example. If necessary, get the patient head down, because your working hypothesis is that it is a relative hypovolemia. Push some bolus of 300 ml of fluid, normal saline or Ringer's lactate, and give the anesthetic time to correct the blood pressure. And later on, if you have to continue your laparoscopy, make sure that the patient is stable for 5 minutes with normal blood pressure, and perhaps you can reduce the rate of insufflation as well as reduce and work at a reduced pressure. If you're working at 14 millimeters of mercury, you can perhaps work at 10 millimeters of mercury or 12 millimeters of mercury, and make sure that you will manage to do the operation, perhaps with a reduced space, but you might still manage to finish the operation. So you're quite right. The first thing to do is deflate the abdomen when there is the slightest of hemodynamic instability. All right. So Indraja talks about, yeah, I'm looking at the chat box again. Reduced cardiac output. Yes, that's correct. Yeah. Incidence of fire after using air. I honestly don't know. I don't remember reading anything in that regard. Can anybody else contribute, please? Incidence of fire after using air. I take it that when air is used, nobody uses cautery. So when cautery is not used, there shouldn't be much of a problem. But the problem with air embolism can still occur, because if you, in the process of banding or whatever, if you open up one of the blood vessels in the area, air under pressure can enter these the bloodstream. And anybody in any of the participants, can they tell us what the incidence of fire is? Okay, perhaps we'll have to look it up, Noli sir. I really can't say what it is. Okay, now let us look at what happens to the pulmonary system. Okay, now what are the things that we look at in the pulmonary system? We mentioned about vital capacity. Okay, and anything else? Can somebody else take it?
Tidal volume.
Tidal volume. Okay.
Residual volume, like the expiratory capacity.
Okay. Yeah. Functional residual volume. Yeah. Okay. All right. Now these are the things that not only is the volume, we also look at the pressure and the compliance. Okay. What does the word compliance mean to you?
The ability of the lung to
expand for a given pressure of insufflation. Okay. So when there is a compression of the lung with a splinted diaphragm, the capacity for it to expand for a given pressure, given inspiratory pressure, will be reduced. That means compliance is reduced, vital capacity is reduced, functional residual capacity is reduced, intrathoracic pressure is increased. Okay. All this put together does two things. It causes hypoxia and hypercarbia. So what do you think the anesthetist will do to counter this during our routine laparoscopy?
Hyperventilate the patient.
Yes, he increases the vital capacity, he increases the inspiratory pressure, okay, and he makes sure that while he does that, he doesn't do something to cause barotrauma. That is the important thing. One of the negative side effects of these is to cause barotrauma. In other words, you can end up with a pneumothorax if you are not careful with it. So that is something that they'll be looking out for. So as you know, in an average person, we do hundreds and thousands of laparoscopies. Unless there is severe cardiovascular or pulmonary comorbidity, an average person, in spite of all these physiological and mechanical effects, can take laparoscopy very safely and very easily. And in case you have a person with a cardiac or a pulmonary incapacity, is laparoscopy contraindicated? That's the next question. Govardhan, can you take this, please? Can you unmute yourself? Yeah.
Yes, sir. Good evening, sir.
Good evening.
I couldn't get your questions.
If the patient, we made the point that in an average normal patient with no cardiac or pulmonary comorbidity, laparoscopy can be undertaken very easily and safely in spite of all these physiological effects on the cardiovascular and respiratory system. But my question is, if the patient has cardiac or pulmonary incapacity or comorbidity, is laparoscopy contraindicated?
No, sir, it is not contraindicated.
So what precautions would you take to make sure that you do not damage the patient during
Yes, sir.
laparoscopy?
If the patient is, for example, a case of COPD case, then we would make sure that because the functional residual capacity is very high, we can sorry, sir, we can still create a pneumoperitoneum and still operate. And if there is any cardiovascular abnormality, say congestive cardiac failure, then we can monitor at low pressures, low pneumoperitoneal pressures, and then go ahead with laparoscopy.
Right. Now, those are not what the classical things are, but if you have, one of the things is optimization, pre-op optimization. Get your pulmonologist or physician and a cardiologist's opinion to make sure that the patient's condition can be optimized before you undertake laparoscopy. Okay, that's number one. How do you optimize? Always, you cannot do anything about the restrictive element of somebody's lung, but the obstructive element can be corrected by a brief period of nebulization, chest physio, okay, chest physio, nebulization, and attention to stopping smoking and things like that. For a cardiovascular disease, if the patient has IHD, you can perhaps optimize their blood pressure treatment, optimize their vasodilator treatment, if any, and in case if they have a very significant cardiac morbidity, you might even consider dealing with the cardiac morbidity first before doing your surgical operation, if that can wait. That's, of course, making sure that it's not an emergency. But at the time of surgery, what you can do as a surgeon is to, as we did with the person with the cardiovascular collapse that we described, work at a lower pressure than usual, learn to work at that, and then also avoid sudden deflation and sudden inflation. It's also good to have avoided altogether, even in normal people, because it is known that the pain will be a little more if you have sudden deflation and sudden inflation. It's always better to have gradual deflation and insufflation when you do laparoscopy. So as we're coming to the pneumoperitoneum effects, peak inspiratory pressure will be high, pulmonary compliance will be low, vital capacity will be low, functional residual capacity will be low, and intrathoracic pressure will be high. Okay, these are the metabolic effects on the heart and the lungs. Can I bring in our seniors here, please? Guru Shantapa, sir, you have anything to add up to this point, sir?
Sir, I do accept theoretically all the explanations, but for the postgraduates, if you just highlight that if the patient has got cardiac or pulmonary problems, major problems in the form of the low function of the cardia or a restrictive or obstructive the airway diseases, they should become a relative contraindication for doing a laparoscopic surgeries. Even if can be optimized, probably the message to these people should be, yeah, they should be a relative contraindication for doing a laparoscopic surgery.
Yeah. Point
Because
taken,
the
sir.
priority is
Yeah.
safety of the outcomes.
Yeah.
So they should carry that. Yes, they become a relative contraindication for doing laparoscopic surgeries.
Yeah, agreed.
Because
As I said,
the anesthesia required for laparoscopic surgery is the general anesthesia. Otherwise, they will start answering laparoscopy can be done under spinal and epidural, and even if the patient has a cardiac or pulmonary problem, still we can go ahead. That is how they will start answering the thing sometimes.
all right. Point
I
taken,
feel
sir.
so. I feel
All
so.
right.
Yes,
Ravi,
sir. Yes,
do you have
sir.
anything to add? Ravi, are you there? Anything to add?
Yeah, what the anesthetist does to overcome this problem, apart from all that was mentioned, he can also increase the PEEP, which not too much, but keeping it at 10 maybe will help to pump the oxygen to the periphery and help to reduce the problems associated with laparoscopy.
Yeah. Rajshekar?
Sir,
Thoracic
preoperative optimization, as said, is the best way to get the patient more suitable, more safer, unless it's an emergency.
Yeah. Okay. So we talked about space. Ramkrishna, sir?
Sir, two things I wanted to know. One thing you said, sudden decompression increases the pain. But we have been seeing papers which says active deflation using suction. It causes less postoperative pain. This is one thing. And the second thing, as Dr. Gushant was telling, if the PG says the laparoscopy cannot be done, can be done with spinal anesthesia or epidural anesthesia, is it a wrong answer, sir?
Yeah, my answer to the first question, we cannot, I really have not read anything where it says that sudden deflation with suction can reduce pain. But what I have seen is papers where, for whatever reason, if you suddenly, because of smoke most of the time, if you let the gas out quickly and then quickly insufflate it again, both taken in unison, not in isolation, the continuous process of sudden deflation followed quickly by sudden inflation, I've seen many papers you say will cause increased pain. That's the answer to the first one. But sudden deflation by itself, without being followed by insufflation, if you have seen those papers, I'll take your statement, because I have not seen any of those. Yes, Guru Shantapa sir was giving I think a generalization for the postgraduates, for them to carry non-confused solid information. But again, in real life, you will see that many anesthetists give spinal for laparoscopic procedures also. Okay, I have also done them, but not on a routine. I personally, as a surgeon, do not like spinal anesthetic for patients, for the simple reason that we rotate them in very odd positions, and if they're awake, it unsettles them. It doesn't give them pain. I've done both hernias and cholecystectomies under high spinal, but it makes them uncomfortable, and I do not want them to undergo that discomfort. And also, splinting of the diaphragm can still give them some shoulder pain, because your spinal anesthetic does not reach that level. But yes, again, we have postgraduates, and this is a postgraduate teaching session. I agree with Dr. Guru Shantapa that as a baseline, cardiac and pulmonary comorbidities are relative contraindications for laparoscopy, and the preferred anesthetic of choice for laparoscopy is general anesthesia. I think it's reasonable to say that. Okay, go on.
So I think that is the main thing. As you said, it can be done under laparoscopy and spinal or epidural, but the significant problem is severe shoulder tip pain, which they experience, which makes them very uncomfortable.
Yeah.
And second thing, what Dr. Ramakrishna said, maybe is if, for example, at the end of the procedure, you actively suck out all the air from above the liver and things, that will give them less post-operative pain, because the carbon dioxide, getting converted to carbonic acid and all that kind of stuff. So I think that is all I think it is. I think you are right about rapid decompression and rapid insufflation.
Yeah. Okay. So
Sir,
yeah,
one more.
go on, sir.
The shoulder pain, is it because of the diaphragmatic irritation with carbon dioxide, or is it because of the anesthesia? Because in both GA or spinal, that this carbon dioxide will be there. How does it make difference in the shoulder pain?
Shoulder pain is because of stimulation of the diaphragm, but they do not appreciate it in GA because they are asleep.
No,
Whereas
post-operatively, when they come out of the anesthesia.
both of them get it. So both get shoulder
So
pain.
it should not be an argument for
no,
not
post-operative, operatively.
Operative discomfort in the shoulder, sir. When we are in steep positions, head up, head down, rotation to the lateral rotation, that is what gives them discomfort. In addition to that, you have the shoulder pain. Yeah.
Sir, when papers are coming out, even in anesthesia journals, that the spinal and epidural can be used, and it has been accepted in all over by anesthetists.
Yes.
Why we should insist that it is a relative contraindication, or you should not do? Why that PGT thing should be different from practical?
Guru Shantapa, sir, can you take that?
Sir, Ramakrishna, he has this discussion many times, but for a teaching program for the postgraduates, I think the anesthesia for any laparoscopic surgery is general anesthesia.
Yeah.
Yeah.
Okay.
What is being practiced maybe with a different views, but with a scientific evidence and for the postgraduates at the teaching level, probably it is a general anesthesia. What is the preferred anesthesia for laparoscopic surgery?
Okay.
And
Nikita,
just with his continuation of his question, it is ultimately the amount of residual gas under the diaphragm is one of the factor for a post-operative shoulder tip pain. It is the amount of residual gas. That is why we should see that everything is emptied before we close the ports. Yeah. Whether you do it suddenly or whether you do it slowly with a decompression, that may not matter much. But it is a complete deflation of the intraperitoneal gas, which will definitely get down the pain in the post-operative period.
Okay. Nikita, we have put something in the chat box, some reference. What does it say? What is it about?
Sir, it is about use of air in laparoscopic surgery, sir.
Yeah.
And it was done in 368 cases, sir, which showed no combustion even after using diathermy, sir.
No, please, it's the wrong message. Please never, they may be right, but kindly don't ever use air, particularly when there is diathermy being used. Okay. Yeah, I agree, but this is something which is potentially dangerous. And so I think it should never be done. Okay. Now we talked about abdomen being a potential space. It's also a dark space. There's nothing that you can see if you don't have good light. So how do you light up the inside is the question. All right. And the question is, we use a cold light source. What is a cold light? Can somebody take this, please? Arvind Somvamshi. All right, Indraja.
Sir, I'm not sure, sir. I think the hot light just.
Are you outside somewhere? All right, go on. Go on. You're not sure. Just guess. What would be a hot light?
Yes, sir. Normally, light will produce heatness.
All right. Suraj says does not generate heat. Quite right. But can you give me a little more details about that, Suraj?
Sir, usually sources like halogen are used. They create halogen bulb source. They create heat.
Yeah,
so
every light creates heat. Only when, for example, if it's an electrical bulb, for example, there's a lot of resistance. And when the resistance increases, there's a lot of heat. Some of that heat gets emanated as light, 5 to 10% of that heat. Basically, it's heat. That's why it's in a vacuum. All right. So my question is, what do you think that kind of temperature is that would give you that heat? Okay. Light emitted by any body whose temperature is below that of incandescence. Incandescence is a phenomenon where the heat of any material gets emitted as light. Okay, and that is considered generally 2000 degrees centigrade. Okay, and another simpler definition is a visible light from whatever source unaccompanied by appreciable amounts of infrared component, having therefore little heating effect. Okay, that's all there is to it. And it's very important that the light source that we use in endoscopy, in laparoscopy, doesn't heat and burn the insides. Okay, the next question is, the cold light that we use, is it really cold? This is something of great interest, and these are all published material. So what do you think the temperature at the end of the telescope is when we use, it's of practical significance. It's not just theory, because I keep talking to my young colleague, when it brushes it against the ball or the omentum or the liver, don't do it. I said, take it out and clean it. Because what do you think is the temperature at the end of a telescope using a conventional cold light source that we all use? What is the temperature of the organ inside? Or the surface of the ball or the liver or whatever. What is the temperature?
Normal body temperature.
Normal body temperature, right? Nothing else. 37 degrees centigrade, 38 degrees, whatever. So what would be the temperature at the tip of your telescope? Okay, this is the answer. In a conventional light source that we use, Indraja had written 60 to 100. She must have seen, somewhere. That's good. Yeah. Okay. So if instead of putting it in the chat box, you are welcome to unmute and give it out. Okay, that's important. Anyway, at the outlet, it is about 750 degrees. At the tip of the fiber optic cable, it's 250 degrees. I don't know if you had it or not. I have had situations when I have left the light cable coming from the cart, coming from the trolley, left it on my draped patient, and I have taken a few minutes to clean my telescope and then attach the light cable to it. In the meantime, I've had a little burn hole in the greens that I have used to drape the patient. I'm sure some of you must have had the same.
Sir. Yes, sir. It happens, sir. It happens.
So it's the tip of that cable that comes is 250 degrees. It's very hot. And the tip of your scope is 60 to 100 degrees, which is a minimum of twice what the normal temperature is. So that's why we recommend that when you have to clean the scope, don't wipe it against the viscera. Okay? No, it's not Fahrenheit. It's not Fahrenheit. Suraj stays, is it not Fahrenheit? No, it's not. It's centigrade. Okay, so that's what it is. Now, you need to generate light, and Suraj mentioned about halogen. What are the kinds of bulbs that are used in a light source?
Sir, can I come in?
Please come in, sir.
Sir, most of the time they rub it against the organs, like the peritoneal surfaces or liver. You said just now it should not be practiced. So we should stop it, sir. Means take it out and clean it, and again you put it.
I've practiced it. I've practiced it also. We take it out. We don't rub it against the viscera. We take it out, and we have a tub of boiling water all the time on the trolley, sterile boiling water. And we dip it into that and then clean it. And it has the advantage of heating. People use Savlon, people use betadine to clean it and all that. And those things can be used. I'm not against it, but they can change the white balance.
Fogging, sir. Fogging, will it help?
I know, but this temperature, the water is the best because it doesn't change the white balance. If you have a betadine, you will have a brownish hue to your image unless you correct the white balance. Similarly with Savlon, which has a yellow hue. Whereas with water, it is heated. You dip it in water and clean it. It heats the tip of the scope beyond 37 degrees, and so there is no There is no, fogging. Gurushattama mentioned tip of the scope may be done over the surface of the liver or abdominal wall, but not over the coils of the bowel. Yeah, but as I said, perhaps it is best to avoid any kind of rubbing of the tip of the scope over the viscera anywhere, because it's twice as hot as the body temperature is. Okay, and so I just use boiling water. It's always done that, very cheap, very easy to have, and does the job well. So I see that we have had an excellent discussion, but we are going on in time. We have a lot more to discuss, and so we will have another session rather than go on with this for a very long time. We will stop at 1 hour and we'll reschedule. I mean, we'll schedule another session to take the rest of the basics of laparoscopy. But I'm particularly happy that we have had some very nice discussion in this session. So what are the bulbs that can be used? Who will take this? Praveen, you've been very quiet today. Praveen, are you there? Okay. Swarna, can you take this, please? Identify yourself. Where are you from? No response. Okay. Vinod, take this call. Take this question, please. What are the bulbs that can be used in the light source?
There are xenon bulbs and halide bulbs.
Okay. Only two?
I know only.
What is the latest here? Where we use our OT lights have changed, everything. What is it that we use?
LED.
LED. All right. So if you're looking at the quality of these bulbs, what are the things that you'll be looking for? What would you like to see in these as a surgeon?
Luminosity. Sir.
Luminosity, very good. How bright is it? Yes.
Heat.
Whether it is really a cold light source, agreed. How long does it last?
Hours.
What is the color quality? Will it really give you a reflection of the true colors of the inside organs? Okay. Okay, so this is it. Halogen was the good old standard. They have an average life of 2000 hours, which is not bad, but it is less than the later ones. Then you go on to the xenon, which has a longer life, brighter white light, and it mimics the natural colors of the internal organs because it resembles sunlight the most. Okay, now replaced by LED, even longer than either halogen or xenon. It is the coldest and gives you the best image in terms of the clarity, brightness, and the natural colors of the internal organs. So as of today, LED is one of the best sources of cold light external source that is available. Okay, those are the advantages. Now, it's not enough if you have one machine emanating light. You must somehow bring it onto the telescope, and you have to bring it out through cables. What are the types of cables that you know of? I see a Rudra Muni. Can you unmute and talk about it?
Hello, sir.
Yeah, go on.
Sir, I didn't get the questions. Please repeat.
What are the types of cables that you can use to transmit light from the cold light source to the telescope?
Types of fibers.
Okay. Before I put the answer on the screen, Nikita has a question about the cost. Okay, the cost of LED now is acceptable, Nikita. I do not know the exact cost, but it is not very much more expensive than either halogen or the xenon lights. Okay, because whatever marginal initial cost may be is made up by its longevity. It lasts much longer, and so it's pretty good. So Mahana says fiber optic. I agree. Is there any other cable? Is fiber optic the standard today, or is there anything else? The gel, correct, Nikita. It's gel. All right. Now, what is the principle under which the fiber optic cable works?
Total internal reflection, sir.
Total internal reflection. Very good. What do you understand by that?
The light from the source gets reflected at multiple surfaces. That is, like at 90 degrees, it
Is
gets
it reflection or is it refraction?
Reflection, sir. Total internal reflection.
It's called total internal reflection, but the phenomenon actually is a refraction.
Yes.
It goes from one medium to another. All right. So when that happens, refraction occurs, and at a particular angle, okay, instead of getting refracted, it gets internally reflected. Okay, and that keeps perpetuating so that there is complete total internal reflection, which actually is a refraction phenomenon, and the light comes out at the other end. And how does it differ from just a reflection?
Inverted image.
No, that's not the main thing. There is no loss of light. For example, in reflection, there is always a loss of light. However good your mirror is, there's a loss of light. But in a total internal reflection, there's no loss of light. And if these bundles which are about 7 angstroms, the size of an RBC, that's the size of a fiber. If these are arranged at random, it just transmits light. And if it is, yeah, Manisha, I'm not saying refraction, that's right, yeah. And if these bundles are arranged in very orderly fashion, it can actually transmit image as well, not just light. So in a fiber optic endoscope that we use, you have 2 types of bundles. Earlier days, and nowadays it's all digital, but earlier days when we were using fiber optics, you had two bundles which were irregularly arranged because it's cheaper to make them. They would transmit light into the stomach or the colon, as the case may be. But there was one bundle which was orderly arranged, arranged in a very orderly manner, which would transmit the image. Okay, so for laparoscopy, do we need only transmission of light or do we need transmission of image? Both. Only light. Okay, so we have fiber optic cables, and this is the phenomenon that I was talking about. Okay, so when there is light going from one medium to another, this is called a critical angle. Okay, this angle where it gets reflected back is called a congruent fibers transmit image. Correct, that's what I meant. Orderly fashion that's what I meant. Yeah, okay. So total reflection is this, and this keeps on happening like this, and this is the way we bend light. Otherwise, you need, as you know, you cannot bend light, and if you must have a solid straight tube if you want to do it, and that's not practical in any laparoscopic procedure. But here, because of the use of the phenomenon of total internal reflection, you can have a flexible tube which will transmit the light, and the bundles can be arranged at random. Okay, but fibers break, particularly if you put them into a tight circle. When you store them, they break, and so you should store them in very loose loops. The whole length must be only in one little loop, like a large U-shaped thing, and keep them in a big tray, and not bundle them up and circle them up. That's very, very important, and you must be very careful not to drop them and not to bend them too acutely while transmitting it. So there is a limitation of the life and the efficiency of a fiber optic cable. Gel doesn't have those disadvantages. Okay, then the gel filled ones are stiffer, so they're more hardy, they don't get broken, and they're more durable. And most of the cables today are gel filled cables. We have come to 10 o'clock. I think we should stop here and invite comments from students first about questions, comments, and doubts. And then I would like the seniors to give their views about what we have discussed so far. And in the next session, we will discuss a lot of things like the other principles of laparoscopy, and then come back to some more information on machines like the principles of the camera, the monitor, the insufflator, and things like that. Okay. Now, comments from students. Please raise your hands and then unmute yourself and give your comments, and if you have any questions, please ask them. Go over there.
Yes, sir. Sir, yeah, I have a question, sir.
Yeah.
Is it
Unmute yourself, please.
hear the question?
You're gone.
Yes, sir. Is it the same principle through which the gel transmits light? Is it total internal reflection, or?
No, the gel is a transmitter of light, and it has multiple particles which does that, and so even if you bend the cable, the light doesn't get lost.
Yes.
Yeah.
Thank you, sir.
Yeah. Nikita.
Sir, in a case of combustion, so what would we do immediately to save the patient, or
Case of combustion, some burn inside.
some burn inside, sir?
Yeah, I hope you never have
Accidentally.
you never have that incident. I've never had one, and I'm sure very few people, if ever, would have one. But nothing you can do except perhaps irrigate it with cold saline to reduce the heat damage. And if an important thing like the bubble is burnt, then depending on the degree of burn, you may have to do a resection of the ball. And if it's a small streak, perhaps you can bury it and see to it that even if that area gets necrosed, it doesn't leak. It depends on which area is burnt. If it's a peripheral abdominal parietal peritoneum, it may not matter. If it's the momentum, it may not matter. But the only thing you can do, I suppose, is irrigate with some cold saline and hope for the best. But if you have any suspicion of a significant damage, it may not occur at the same time. So do not discharge the patient. Keep the patient in and do a planned re-laparoscopy or a laparotomy 48 hours later. Okay, Manas.
Good evening, sir. I just wanted to thank you, sir. Thank you so much for this informative class, and we cleared so many of our doubts, even though most of it is like most of the time whenever we study laparoscopic surgery, we go directly into the procedure and where we place the ports, but getting into basics and knowing the physiology behind it is really important as well.
Thank you very much. Can I come to the seniors now? Guru Shantapasa, your comments?
Nothing, sir. It is really informative for even for us also. For the postgraduates, I think whatever Lakshman sir has mentioned, you should go back and read up again. It is not that everything can be learned in a single 1 hour class. So please go back and read the principles, whatever he has covered. About the burn injuries from the tip of the scope, what you had mentioned. That's why the cameraman should understand the laparoscopic procedure, even though surgeon is doing the procedure. It's utmost importance. That is why every laparoscopic surgeon should be a good cameraman first.
Very true.
Then only he can become a good laparoscopic surgeon. Straightway doing surgery without understanding this, probably we may land up with problems and we may stop doing the procedures. So how far distance, when to go in, when to go out, when to zoom in, when to clean the tip, how to. So there are lot many things which sir has nicely pointed out. So every point in laparoscopy is a really important thing. Sir, whatever, definitely I appreciate your involvement and enthusiasm. For the postgraduate, please respect whenever he calls up the names. Please understand, if somebody is calling up the name, it has got a value. So please do respond whenever he calls up some names, so that it feels like we should continue this procedure. Thank you, sir. Thank you.
Thank you very much, sir. Ramakrishna, sir.
Hello. Good evening, sir. Yeah, it was a very nice lecture, sir. Even after doing laparoscopy for so many years, I thought I didn't know so many things, and I learned it. And one thing it was not highlighted is air embolism. How you diagnose air embolism and what immediate precautions you should take when you suspect it?
Yeah. Two things that you can do. Again, desufflate. First, diagnose it. Diagnosis is when a patient suddenly crashes and the anesthetist auscultates the heart and listens to or hears what's called a machinery murmur. Okay, there is a lot of churning of air bubbles inside the heart, and so it's heard as a continuous murmur by the anesthetist. One should be aware of this and one must be able to diagnose it. When that happens, you have to desufflate. As a surgeon, all you can do is desufflate, let the gas out, and those bubbles should not reach the brain. That is the main thing. If it reaches the lung, okay, it can get churned up there and perhaps may kill a bit of the lung, but the patient will survive. But if the bubbles go into the brain, they may have a fatal stroke. And so to prevent it from going to the brain, you must get the patient head down. That's what the anesthetist does. That's what's been recommended. Fortunately, we have had no such emergencies, touch wood, for the last, since 92 that we've been doing this. Anybody else, have you had the experience of an air embolism? And have you anything else to add to what I have said, please?
Sir, shall I?
Please.
Not a very common entity with CO2, but if it happens, it's a head end which will recognize. And if an operating surgeon feels some changes in the blood, whatever we are seeing in the inside the abdomen while operating, even a slightest change, we expected a bright red, but it is a little darker blood, where we expect there is something going wrong, and inform the head end. And it's a head end people, really they should be enthusiastic and find out. And second, since the patients are connected to the equipments and the monitors, best way is to take out that, ventilate, just see what's happening, auscultate. So unless we do that, probably machine will not detect everything. Machine will not detect. So it is the person who is near the machine should detect. So when we have problems like this, it is a head end person is really important. Recognize early. Once we recognize, we have a lot of things to be done and monitor. Sir, I feel because the air is a lighter weight, patient should be head low. The air should come to the apex of the heart.
Yeah, that's what I said.
Otherwise, it will go up. Otherwise, it will go up. So make head low and see that, and the left upper, the right upper, that is left lateral. Hoping that the air will come into the apex, and if you have proved, do a echo on table and try to aspirate that air with a needle into the heart. That is what is theoretically mentioned in the books for air embolism.
Nuli, sir, your comments, please.
No, sir, everything was very good, informative, sir. Thank you, sir. Thank you.
Niranjan?
Sir, it was very good, sir. Only one point when we are talking about spinal anesthesia, with respect to laparoscopy, GA is any day safer, especially in patients who have comorbidities, than spinal. So if you're attempting laparoscopy, it has to be GA, even with comorbidities.
Yeah. Okay.
That's it, sir.
Yeah. All right. Rajshekhar?
Sir, at least you need 2 more hours.
Yeah.
At least that means 2 more classes. One to cover the ergonomics.
Yeah.
Then to positioning, then to etc. Then to come to the advances in laparoscopy. I think we should take it into as many classes, maybe 3 or 4 classes, and go slow. Build it over
That's
it.
exactly,
Let's not rush to finish the class.
I've really covered only 30% or 40% of my
There's
people.
a lot more to it. Yeah.
Okay.
Thank you.
Final comments from Ravi Shankar. I hope I've not left any other seniors. From what I can see, all of us have participated. Okay, Ravi Shankar, final comments and then we close.
Thank you very much, sir. I think it was informative both for the students and for us. Lot of finer points I think you touched upon. I think it is important for the absolute basic principles to be understood, as Mehanaz or she said that we directly go to the procedures. I think the first chapters need to be read and reread many times. And I think Professor Gurushantapa's words that you should go back and read is very important. And thank you very much, sir. I think this is very informative for everybody. I think we should all go back and read up so that we brush up our basics again and again. Thank you.
Thank you. I think I really have enjoyed this discussion, and I hope we will schedule and inform you about further classes on basics of laparoscopy. When we continue, please, all of you, attend so that we can have an equally healthy and informative discussion. Thank you and good night.
Good night, sir.
Thank you.
Good night.
Nice.